association with the at the University of New Mexico. These sessions are held weekly on a Wednesday at 4:30 South African time. We have 47 registrations received from 13 countries. The chat will be open for questions. Our first presenter is Professor Watermeyer, needs absolutely no introduction. She's going to do a complex case of Crohn's disease. When she's done, we will take questions, and then I will introduce the second lot of talks. Thank you and enjoy the talks. Over to you, Jill.
Thanks, Mash. Gonna share slide share. Can you see?
It's coming up. Yeah, we can see it, Jill. Thanks.
And it's in full screen.
Yeah.
Okay. All right. So I'm going to present a complex case of Crohn's disease that we've recently been struggling with. So this is a 32-year-old woman. She's a single mother of one child, long-standing heavy smoker, and she's currently unemployed. She was diagnosed with Crohn's disease at the age of 10. Initially treated at Red Cross Children's Hospital, and then transferred to Groote in 2008 at the age of 17, which is often the scenario. At diagnosis, her Crohn's disease was limited to the colon. It was left-sided with essentially normal small bowel and normal or proximal colon. She also had iron deficiency and folate deficiency at diagnosis, and she was treated with cilazapyrene, iron, and folic acid. And with this treatment, she was in long-standing clinical remission. Then in 2013, she developed pulmonary TB, which fortunately was rifampicin sensitive, and she was treated for 6 months. Unfortunately, she defaulted follow-up at our clinic until 2015, and this has unfortunately been a repetitive scenario that we have encountered. And then she came back to us with a second bout of pulmonary TB. This time she was treated for 9 months, and again, it was rifampicin sensitive. Unfortunately, she thereafter developed post-TB bronchiectasis. Her Crohn's disease remained quiescent clinically between 2013 and 2018, and her medication was essentially unchanged during this time: cilazapyrene, iron, and folic acid. Then in May 2019, she presented with diarrhea, weight loss, abdominal cramps, and she had a colonoscopy which showed severe left-sided colitis. She was given a course of oral prednisone, and she was started on subcutaneous methotrexate weekly. This was after we had done a negative sputum gene expert for TB. Methotrexate was chosen over azathioprine due to the risk of TB reactivation, and she was also given INH prophylaxis. Over the following year, there was very erratic clinic attendance, and when she came back to us in March 2020, there had been no response of the 10 months of methotrexate, but compliance was very questionable. Repeat colonoscopy showed quite a similar picture: severe left-sided colitis and a narrowed sigmoid colon. And again, she was started on prednisone. This is her second course. The methotrexate dose was increased to 25 milligrams weekly. The cilazapyrene was switched to Asacol, and Intesa suppositories were added because she had quite severe rectal involvement. Again, she defaulted, this time for 7 months, and she stopped all of her treatment and presented to us in September of 2020. With ongoing symptoms of diarrhea, loss of weight, and cramps. Repeat colonoscopy pretty much showed exactly what it had done over the last year or so, with severe left-sided ulceration. The rest of the colon and the terminal ileum were normal. She was treated with budesonide enemas for 2 weeks, and again given a short course of oral prednisone, something that we absolutely hate doing because this is now her third course. The methotrexate was recommenced at 25 milligrams weekly. At this stage, we motivated for vedolizumab, unfortunately unsuccessfully. For those of you who don't know, vedolizumab is a monoclonal antibody targeting alpha-4 beta-7 integrin and preventing its binding to MADCAM on gut endothelial cells, essentially preventing leukocyte trafficking into the areas of gut inflammation. Ustekinumab is another biologic which is pretty safe. It is a monoclonal antibody targeting IL-12, IL-23, but this was not an option due to the expense of the drug currently in South Africa. In January 2021, this is 4 months later, still no improvement really in her symptoms. And this time, I think she might have got a little bit of a fright because she claimed to have been compliant on the methotrexate. Again, scope shows ongoing severe left-sided colitis. We screened her for the upadacitinib trial, that is a JAK-selective inhibitor. And she was turned down because of having had pulmonary tuberculosis twice in the past. It was an exclusion criteria. So what do we do next? We have a 52-year-old woman here. previous pulmonary TB in 2013 and 2015 with severe ongoing Crohn's colitis, unfortunately complicated by some compliance issues. She's had 3 courses of steroids in 18 months and a minimal response to methotrexate at maximum dose. Just a test X-ray on the right there looks a bit scary, but in fact, it's unchanged completely from 2016, 2019, and 2020. So there was no evidence of active TB. So what do we do next? Switch to azathioprine, try an anti-TNF, or consider surgery. So I'll tell you what we did. But first of all, would we switch to azathioprine? Well, very reluctantly, given the compliance issues here, because for us to treat a patient safely with azathioprine, we really need them to come back quite religiously for blood follow-up to make sure that they don't develop a drug-induced liver injury or a severe neutropenia. What about surgery? Well, we were a little bit reluctant again, because this is a young woman. She's got rectal involvement. To do surgery is probably going to subject her to a lifelong stoma. So we decided to try an anti-TNF with much trepidation. So the adalimumab biosimilar was started in June of 2021, together with full INH prophylaxis. She received induction and 2 maintenance doses, and again defaulted this time for 6 weeks, so she had no adalimumab during that time, but it was restarted in August 2021. And she was compliant during this time. But in January of this year, she presented to our clinic with 2 weeks of bilateral pitting edema. An ultrasound showed a distal DVT of the left calf. She was started on warfarin, and the idea was to give this to her for 3 months. She also described ongoing diarrhea and abdominal pain, and flexible sigmoidoscopy again shows severe left-sided colitis with sigmoid narrowing. We did therapeutic drug monitoring, and her Prof level came back as extremely low without the presence of anti-drug antibodies. This could, of course, mean non-compliance, but we elected to rather just increase her adalimumab biosimilar to weekly, assuming that this was due to very severe disease and loss of protein through that really damaged, inflamed left colon. In May 2022, however, this was just a few months later, she presented with 2 weeks of worsening shortness of breath and significant loss of weight. On examination, she was systemically unwell. She had a tachycardia, she had a temperature of 37.5, she was markedly cachectic, weight of 33 kilograms and a BMI of 12. She had bilateral pitting edema. On examination of her chest, she was tachypneic with stony dullness of the right base with reduced breath sounds. The abdomen, she was thin in the left iliac fossa, but otherwise quite unremarkable. She had a hypoalbuminemia of 22, a markedly elevated CRP of 111. She was anemic, which was shown to be due to iron deficiency. She had a marked thrombocytosis of 684 in keeping with her severe inflammatory bowel disease. She had hypocalcemia, hypermagnesemia, and her vitamin B12 was normal. So unfortunately, this was the chest X-ray showing a fairly sizable pleural effusion on the right-hand side, possibly some new infiltrates up on the right upper zone. And a pleural aspirate was done, and this was gene expert positive for Mycobacterium tuberculosis. Sputum at the same time also sensitive for Mycobacterium tuberculosis, and again, rifampicin sensitive. She had an ultrasound at that time because of marked pitting edema that was still present, and it showed that the DVT had not resolved with the warfarin, but it had now actually extended to the left femoral vein. So she was started on warfarin again, and also full TB treatment, and obviously we stopped the adalimumab. She required a prolonged admission, 6 weeks, for nasogastric tube feeding, intravenous electrolyte replacement, and on discharge, her weight had actually increased by 9 kilograms to 42 kilograms. An MRE done on that admission showed a long segment sigmoid narrowing and active colitis again. Flexible sigmoidoscopy again showed the same picture, active severe left-sided Crohn's disease, currently on, of course, no treatment. So this time vedolizumab was motivated for and approved. She was given a short course of prednisone as a bridge to vedolizumab, and so far she's had her second induction dose. So we wait to see how this will work. Unfortunately, vedolizumab does not work particularly well in anti-TNF failures. So just briefly about reactivation of TB, a very important consideration in patients who require anti-TNFs. I think we're all aware this has been known since the early days. The risk is dependent on the local disease burden of TB. And we have a retrospective study of almost 5,000 South African patients with rheumatic diseases in South Africa on anti-TNFs. And the incidence rate of TB was 10 times higher than that reported in similar European cohorts. The risk of TB reactivation increases significantly if it is combined with immunomodulators like methotrexate or azathioprine, and it's also considerably higher if corticosteroids are also initiated, and with corticosteroids, higher doses confer a greater risk. So what is latent TB? Well, it's a persistent immune response to stimulation by Mycobacterium TB antigens without evidence of active tuberculosis. And it's a big problem in sub-Saharan Africa, where we see an incidence of about, a prevalence of about 66.6% in a meta-analysis of studies based on tuberculin skin testing, and 33.6% with data based on the IGRAs. So just to give an idea of the scale of the problem, in a retrospective South African cohort study of 614 patients with IBD, and this was actually from our clinic, 12% had either had TB before or after IBD was diagnosed. And of these, 44% had developed TB after their diagnosis of IBD. And of these patients, 17% had been exposed to immunosuppressive therapy of some form or other within 6 months of TB diagnosis. So essentially all patients who will be treated with an anti-TNF must be screened for latent tuberculosis. So how is it diagnosed? Well, there's no gold standard test. The WHO recommends a chest X-ray and either a tuberculin skin test or an IGRA. The availability and affordability will depend really on which one will be chosen. Both of the tests have fairly low sensitivity and they can be falsely negative, particularly in immunocompromised individuals. Just to point out that in IBD patients, regardless of whether they are on immunosuppression or not, tuberculin skin test of 5 millimeters or more is considered positive. Unfortunately, neither the TST or the IGRAs can differentiate active TB from latent TB, so they're not suitable for the diagnosis of active tuberculosis if one is concerned about intestinal tuberculosis. If neither of these tests are available, which is the situation that we're currently faced with, it is not unreasonable to empirically treat for latent TB, provided active tuberculosis has been excluded. So all patients who have latent tuberculosis need to have some kind of treatment to reduce the risk of reactivation. Typically, this is 6 or 9 months of daily INH, and the efficacy ranges from about 60 to 90%. And a meta-analysis of placebo-controlled study shows the odds of reactivation in patients treated with INH was 0.64. So it doesn't completely alleviate the problem of reactivating tuberculosis, but it does make a difference. So other options are now also recommended, such as shorter rifamycin-based regimens, which are becoming more affordable, have a better safety profile and have better adherence. But I think in the subcontinent here, we're still going to be forced to use INH prophylaxis. And this is just some of the recommendations from the CDC, WHO, and the National Institute of Health in the UK, just really showing the different recommendations, which include 4 months of rifampicin daily, which I don't know how happy we would be to use here, rifampicin plus isoniazid daily for 3 months, isoniazid is once a week plus rifampicin, which we don't have available, once a week for 3 months, or isoniazid is daily plus rifampicin daily for 1 month. So I think this is just a very challenging case showing essentially how often we are stuck between a rock and a hard place. And unfortunately, the gamble here for our patient didn't particularly pay off. So let's hope she responds to the vedolizumab and that we haven't damaged her lungs too significantly more with the third bout of pulmonary tuberculosis. So thanks very much. And I'm going to stop screen sharing.
Fantastic, Jill. Thanks for that case. I think for the fellows, it's an instructive case about what can go wrong in a patient with IBD. I mean, this patient showcased all the complications that you can anticipate: malnutrition, vitamin deficiency, the weight loss, the complication of getting a pleural effusion on biologic therapy, complications of thrombosis with her DVT, And of course, the challenges of managing young patients with IBD in terms of compliance and accessibility and understanding their medications and how to use them. So very instructive case in terms of all these challenges that one can have in the one patient. Of course, we know the patient, and there are no questions yet in the chat, but maybe just to stimulate conversation. Given that we knew that she had had tuberculosis twice before and in fact has TB bronchiectasis, I know that at the time we decided for methotrexate for good reason. If cost was not an issue, would you have considered biologic earlier, or given that her disease was still limited sort of to the left colon, that's not necessarily the choice that one would have had at the time?
Yeah, Mash, so I most definitely would have considered vedolizumab if costs were not an issue up front when she first presented back in 2018 with this grumbling, fairly severe ulcerative colitis. The other option would, of course, be ustekinumab, which I think is probably a better drug in Crohn's disease, but that's also debatable. As a first-line therapy, vedolizumab is a pretty good therapy for Crohn's.
Yeah. And is there any data to show that the risk of TB with adalimumab is better than with infliximab?
Not that I'm particularly aware of. They usually bung together, so I'm not sure of any specific data that would suggest one over the other.
Yeah, I haven't come across that either, but I was just wondering whether it makes it a better choice or not. But I think because the use of infliximab probably overwhelms that of adalimumab, there probably isn't any data.
Yeah.
Yeah. Folks, do you have any questions for Jill, or just general questions about the management of IBD in situations like this?
I see Dion's on the chat. Dion, I don't know if you want to make any comments about the case. You know her very well, and you were quite instrumental in her management. And Dion actually was the person who managed to motivate for the vedolizumab, which I still think is quite a remarkable achievement.
Indeed, yeah.
No, I think you've summed it up succinctly. I mean, it's a very difficult case with lots of, as Mesh says, lots of issues. But I don't think I've got anything particularly pertinent to add. Thanks.
I think, Jill, at SAGES, and maybe prior before that, we reviewed this at Journal Club, screening patients for TB prior to starting immunosuppressive therapy. I mean, as you've said, we are limited in what we can do, but obviously now there's a movement about doing CT, chest, and abdomen, in addition to all the tests that we do. Now, in terms of cost effectiveness for us, feasibility, should we be doing that? Should we be moving towards scanning everybody? Or is there a way in which we can risk assess? For instance, this patient, having had TB twice before with her malnutrition on board, etc. What's your own view about that?
Yeah, absolutely. So I will bow to the far greater experience and knowledge of my colleague, Professor Nita Huja, who was one of our recent SAGES speakers. He's an absolute legend in the field of tuberculosis in the setting of IBD. And he strongly recommends doing CT scan as part of the initial workup before you start anti-TNF. So I think going forward in our practice where it is feasible to do this, we should possibly consider doing this, but I think not in every patient. But, you know, if there's any risk factors, a positive TB contact or something along those lines, I think it would certainly be of value.
Yeah. Thanks. Hi, Tim. Tim asks, if compliance was not an issue, would you consider exclusive enteral nutrition?
Yes, I suppose it would certainly have been an option, Tim, but I mean, this particular patient, in fact, the dietitians gave a huge amounts of supplements at great expense for her to take home, and they were actually found in the toilet. So our dietitians were not particularly happy. So I don't know if that would have been an option in this particular scenario.
I'm just wondering if the video doesn't work, God forbid, we may have to consider nutritional therapies, because I don't know that there's anything else for her. What other surgeries which we know that the problems of, you know?
So I think if the video doesn't work and we cannot get ustekinumab, which, you know, we heard today that there will be a generic available fairly soon because it's been around in psoriasis for almost a decade now. So that would certainly be an option that will be more affordable. But if those are not available, then we're just going to have to take this colon out, which will leave her with a permanent stoma, essentially.
Yeah. And anyway, she has the stricture. I can't remember how long that sigmoid stricture is. So surgery might actually be a viable option depending on how symptomatic she is and how long the stricture is.
The stricture is, it's fairly long, but it's very passable with the scope. And she doesn't really have many obstructive symptoms. It's mostly diarrhea and significant weight loss that are her main sort of symptoms of active Crohn's disease.
True. Dion?
Yeah, I don't know if the enteral feed counts as enteral nutrition. It's not exclusive, but she was in hospital for almost 6 weeks on nasogastric feeds with no active treatment of her colitis. So in fact, she put on weight, but she still had ongoing diarrhea and she still had active disease. So I'm not sure we would even win with exclusive nutrition because she was in hospital.
That wasn't exclusive. She was also eating food as well.
Okay, fair enough.
Yeah. And then what are we going to do about her DVT? I mean,
Mash, I think she will have to remain on warfarin, right? And, you know, because obviously active IBD is a hugely thrombophilic state. We know that. And, you know, she should probably remain on warfarin kind of indefinitely at the moment until we get 100% control of this disease.
Indeed, yeah. I mean, she represents clearly what the data says, that patients with the IBD, active IBD, even after discharge, remain at high risk of clotting, venous and arterial. And in fact, they suggest that even as outpatients, you should be giving them some prophylactic, you know, agents, which maybe in our setting might be hard to manage in terms of monitoring, etc. But maybe there are patients like her who could benefit from ongoing prophylaxis, even post-discharge.
Yeah, absolutely. And as you say, it has certainly been recommended that one should consider something like, but obviously it has to be in the right setting, in the right patient.
Absolutely, yeah, yeah. Any other questions, folk, before we go on to the second lot of cases? As I say, I think this case has got many discussion points. We could go on forever. But if there are no specific questions at the moment, we'll let our second lot of speakers.
Masha, you've lost sound. I don't know if it's just me that can't hear you.
No, my microphone is still on. I think sometimes the network in this office is not great.
I think it's actually my internet connection that's unstable. So if I disappear off, you know what's happened.
Okay. All right. Thank you so much, Jill, for that case. As I say, I think it's a brilliant case, not for the patient, of course, but it's a huge learning opportunity for all of us. So if it's okay with everybody, I'm going to move on to the second lot of cases. And I'm happy that Dr. Wayne Simmonds and Ram Makan from Bloemfontein Universitas have got a couple of cases that they want to present to us. Wayne, welcome, and over to you.
Thank you very much, Mashiko, and thank you to you and the GECO team for the opportunity to present here again. I'm just going to share my screen. Are you able to see that?
Yeah, we're able to see that, Wayne. Yeah, fantastic. Thank you.
Great. So to continue with the theme of infection for the afternoon, I think, we're going to discuss two cases. I'm going to just lead into the discussion, and then Dr. Makan is going to take over and give the cases. And we're going to discuss cases that we've seen recently that gave us some challenge with regards to infective issues with IBD. So if we look at opportunistic infections, opportunistic infections are defined as being progressive infections by a microorganism, and there's a raft of them. These are limited, have limited or no pathogenic capacity under ordinary circumstances, but then confer serious disease, due to some predisposing effect of another disease or that disease's treatment. So the immunocompromised patient, we know them, those with HIV infection, congenital immunodeficiency, leukemia, lymphoma, malignancies, therapy with immunosuppressants, alkylating agents, antimetabolites, radiation therapy, and high doses of corticosteroids. There are other scenarios like hyposplenism, liver disease, kidney disease, which confer such immune paresis as well. When we look at the IBD population, with this sort of wonder world of immune world in the GI tract, we do have, these known aberrant immune responses. These patients suffer innate and adaptive genetic susceptibility to deranged immune system at the gut level. And of course, then we treat them with corticosteroids. The example we've heard about already, immunomodulators and various differences or difficulties with them, biologic agents, the advent of them, with a lot of promise, but then predisposing patients to a number of further risks. The anti-TNFs we've discussed now, vedolizumab, ustekinumab, the newer S1P modulators, which inhibit white cell egress from the lymphocyte and show further promise to limit these systemic effects that predispose patients to infection, and likewise the JAK inhibitors. What we've seen in the previous case, and we'll show today as well, that combination therapy is definitely hazardous with regards to this risk of infection. And then, other factors are described continuously, like older age, patients with active disease, patients with comorbidity, malnutrition we've mentioned as well. And then interestingly, when one looks at the ECHO guidelines, and particularly with regards to infection and risk, the initial guidelines in 2014, the current ones, the latest one in 2021, does not, throughout parenteral nutrition and bowel surgery has particular risks. I'm not sure why, but that's a clear difference there. So I'll quickly hand over to Dr. McCann, who will then give us the discussion about the patients that we saw.
Good afternoon. The first patient is a 37-year-old male patient who is a horticulturalist from Kimberley. He's been known for a very long time to the unit with long-standing fistulizing Crohn's disease. His symptoms first started 15 years ago, and at the time of diagnosis, his Montreal classification showed that he had A1 disease, meaning he was diagnosed less than 17 years old. He had L3, which is ileocolonic disease, and B3 for penetrating, and the modifier P for perianal disease. Initially, he presented in a very poor state. He had perianal disease that was quite severe, and his BMI at the time was 12 kgs per meter squared. He was then enrolled at that time for the vedolizumab clinical trial due to the severity of the disease, but he responded poorly. Next slide, please. All right. So 12 years ago, he had an ileostomy for diversion. And at that time, he was then motivated to be on infliximab. And he was the first patient that was identified at Universitas Hospital to be put onto infliximab. And he then subsequently made a remarkable recovery. He then chose to stay with his ileostomy, which he still has in situ. We see him every 8 weeks at our clinic to give him his infliximab at 5 milligrams per kg. Currently, his BMI is 21. He's clinically well. He even got married in 2020. Next. So this was during our SAGES Congress recently. Patient presented to Kimberley Hospital, and you can see he had a prolapse of his ileostomy there, and he actually required emergency surgery. He had a dusky necrotic segment at around 10 centimeters from the ileocecal valve, and they had to resect 20 centimeters of his ileum. He had a healthy proximal and distal loop with no perforations. So this was an emergency presentation, and thus he had to have emergency surgery for this at Kimberley Hospital. We also, because of the intraoperative theater setting, we decided then to defer his dose of infliximab. Next slide. So when he presented for his next dose of infliximab after the operation, we saw what was described as these dewdrop on rose petal appearance, these lesions that you see on the slide. So after consultation with dermatology, they were convinced that it's an episode of chickenpox, and thus we decided to defer his dose yet again. He was given a dose of acyclovir, and he had good recovery. So 1 week later, when he came back to us, we reviewed him and we see that the lesions had crusted and scarred. We then continued with his dose. Patient was doing well, and we then put him back onto his normal regimen of 8-weekly dosing of infliximab. Next slide. All right, the second patient is a 23-year-old male patient who is a musician from Welkom in the Free State. He lives with his parents. He was referred from his local hospital, which is Kroonstad Hospital, for a workup of his weight loss with chronic diarrhea and blood that was associated. So when he presented to us, he complained of diarrhea every day. At the time of presentation, it was 3 to 4 stools per day. He described it not being related to any type of food or drinks that he had. There was blood present in his stool, and due to the low hemoglobin that he had, the base hospital transfused him. At the time of presentation, he did have night sweats and fever. He said to us that the medication that the base hospital gave him did not help at all. They gave him salazapine and prednisone. He also complained of a stiff back, and he described what we thought was dactylitis previously. He also had a skin rash on the anterior aspect of his legs. So on examination, he was chronically ill and wasted. His blood pressure was low at 105/62. He was tachycardic with a pulse of 104, and he was pyrexia with a temperature of 37.5 degrees. He was also pale and he had leukonychia. On an abdominal examination, his abdomen was scaphoid. He had generalized tenderness. He was not peritonitic, and he had no organomegaly. We then proceeded to do a colonoscopy for him and found that he had a Mayo 3 colitis up to the splenic flexure. We then took biopsies and found that the colorectal mucosa was completely ulcerated, together with cryptitis, crypt distortion, and crypt abscesses. He also had positive immunohistochemical staining for cytomegalovirus. We then initially treated him with ganciclovir at 5 milligrams per kg IV in hospital, and then converted him to oral outpatient treatment at 900 milligrams BD for 21 days. So when we followed him up, he described an improvement of his symptoms. He says he's still having about 3 stools per day, but they were still loose. So not complete resolution of his symptoms. He was then readmitted to us about a month later, then complaining of diarrhea, blood in the stool, and an increase in the episodes of stool per day, 7 to 10. He was also dehydrated. So we proceeded to have a relook colonoscopy, and we took biopsies again. This time we found that he had colonic mucosa with fibrosis of the lamina propria, crypt distortion, and goblet cell depletion. He had a dense inflammatory infiltrate of lymphocytes and plasma cells. So the final summary of the histology was that he had severe acute and chronic colitis with ulceration. So we then continued therapy as we would for IBD ulcerative colitis. He is on azathioprine currently, 5-ASA derivatives for his ulcerative colitis currently. Okay, Dr. Simmonds.
Thank you very much, Ram. That was good. So these cases demonstrate for us, 2 scenarios. One, where a patient is well established and stable on therapy, and then has a complication and predisposing him to this infection, we think, and that went reasonably well. Chickenpox, in the adult, in someone with immune compromise, could have gone much worse than it had in his case. And then a patient who's starting out with an initial diagnosis or primary diagnosis with inflammatory bowel disease, then having a viral infection, sort of skewing his start out of therapy for his condition. So we thought to just discuss viral infections and IBD today. If you look at the current ECHO guidelines regarding this, they discuss very succinctly viral hepatitis, HIV, the herpes virus, HSV, herpes simplex, varicella, including then, our patient Epstein-Barr, cytomegalovirus, human papillomavirus, influenza, and then SARS, COVID-19. What is clear, in the outset of this document is that, we should, and I think in our first patient's case, he was started at a time where, it was quite early on in terms of anti-TNF therapy. And, I'm not aware that we don't get the record that he was screened for varicella zoster at that point. So, this went on, and, it begs the question that, should we, from time to time, keep on asking patients these questions and reviewing the serological screening in patients like this. So the ECHO guideline suggests serological screening for patients for hepatitis A, B, and C, HIV, Epstein-Barr, cytomegalovirus, and varicella zoster and measles. And in those, you would have to do screening in the absence of documented past infection or vaccination. So if you had a patient, who admits to having had chickenpox or zoster, or who has had vaccination, then your serological screening could be deferred in those patients. They end the document then talking about human papillomavirus, and gives focus then to care of that in patients with IBD as well. Scrolling takes a bit of time. So if we look at varicella zoster virus, it's a human alpha herpes virus with the CDC giving us an incidence of 4 cases per 1,000 people annually. The spread is airborne, respiratory droplets, or direct contact with these vesicles. It has an incubation period of 10 to 21 days, with a primary viremia of 4 to 6 days at day 4 to 6, and a secondary viremia of day 14 to 16. So one wonders, in our initial patient, if he wasn't, looking at the timeline, if he wasn't at the point of his surgery or at the point of his prolapse and acute difficulty, if chickenpox wasn't, on board at that stage as well, and whether it predisposed him to the calamity that he had, is a discussion point as well. So varicella zoster causes chickenpox and herpes zoster later on after reactivation. The clinical diagnosis, which was emphasized by our dermatologist, is that of the characteristic rash, and then successive crops of lesions, which is usually self-limiting and gives more significant disease in adults and immune-compromised populations, of which we view patients with IBD as such. There's serious pulmonary disease that has been described now with concomitant COVID-19 that we've seen recently. We look at the reproductive number that again was looked at quite a lot during the COVID time. We see that chickenpox is only second to measles in terms of its infectivity. So, in the population, the IBD population, it's wrong for us not to consider chickenpox as an infective cause for issues. Its management, again, from the ECHO practice guidelines, is that if the patient on screening gives you no history of chickenpox, shingles, or a vaccine, you have to give the patient varicella zoster immunoglobulins if they've been exposed. And the idea is to vaccinate the patient who is seronegative at least 3 weeks prior to commencement of your immunomodulator therapy. And that would be a biologic agent, that would be an immunomodulator like a thiopurine or methotrexate. The problem is there are lower conversion rates on therapy, so particularly with anti-TNFs. And it said that once you start a patient on therapy and attempt to vaccinate the patient afterwards, you actually have to stop the immunosuppressant therapy for 3 to 6 months to guarantee a good response to vaccination. So that's rather problematic, and it emphasizes the point to screen and vaccinate these patients timelessly before initiation of immunomodulated therapy where possible. Seronegative patients should receive post-exposure prophylaxis should they have then been exposed within 10 days of that exposure. So active chickenpox or herpes zoster, it's advised not to commence immunomodulated therapy during that time, and that one should treat the patient, and if you treat the patient, you discontinue the immunomodulator if the patient was on one in the severe cases, and then reintroduce the immunomodulator after all vesicles have clustered over and the patient's fever has resolved. So fortunately for our patient, he was started then on acyclovir. We gave oral therapy in his case, initially in the initial site of those vesicles, and he sort of had an ideal course. He recovered well and lesions clustered well within 5 days, and it was not necessary to give him intravenous therapy. We did defer his anti-TNF, as said, and then we restarted his therapy after all the vesicles were observed to have clustered. And he hasn't reported any difficulties with this. It's been, I think, 2 weeks now, and there's been no difficulties after reintroduction. We switch over to the second patient and the cytomegalovirus. This is from the herpes viridae family, human herpes virus 5. The initial infection with CMV is often asymptomatic or giving a mild flu-like illness, but in immune-compromised individuals, it can give much more significant disease with an initial mononucleosis syndrome, but then going on to involve any organ in the body. Can give fever of unknown origin, pneumonia, hepatitis, encephalitis, myelitis, a number of neurological issues, uveitis, retinitis, neuropathy, and in our patient, the problem of colitis. So the diagnosis is made with the symptoms, which can be upper or lower GI symptoms, the typical mucosal lesions or ulcerations seen on endoscopy, detection of cytomegalovirus, either by culture of tissue, histopathology, immunohistochemistry, like in our case, or FISH. And then the difficulty with PCR alone is that, a positive result may simply reflect transient viral shedding and not real disease as such. It makes it challenging. These ulcerative lesions can occur in the oral cavity, the esophagus, CMV esophagitis, a typical problem that we do see from time to time, gastritis, then colitis, giving diarrheal illness, which can make the diagnosis of inflammatory bowel disease or hamper the diagnosis of inflammatory bowel disease. We see that concurrent CMV colitis worsens the prognosis of active IBD, and it's paramount that patients with difficult to treat, patients with severe disease, and patients with refractory IBD should be tested with CMV colitis. This includes patients that return with acute flaring of disease or severe acute flaring of disease. In the literature, I find it difficult to find, this distinguishing between latent and active infection. So that's still unclear. As with transplant medicine, renal medicine, it's difficult to find a serum DNA level that can predict or give clear indication that this is active disease in that area where one suspects to have cytomegalovirus involvement. So in the studies that I've read with CMV colitis, those studies used 250 copies per mole as a DNA level to indicate disease. There's usually a poor response to immunosuppressive therapy, and that's the tricky part with patients. So you start a patient with IBD, on the immunosuppressive therapy, and there'd be a poor response to that therapy. And I think that would be an indicator that one should think about CMV in that setting and rebiopsy if necessary to make this diagnosis. Immunosuppressive therapy should not be discontinued in established patients with intestinal CMV reactivation. You should taper your steroids, but without systemic features of disseminated CMV infection, one should really push on with the immunosuppression and treatment of the IBD, bar the steroids. And some literature says combination therapy. Antiviral therapy should be then considered in steroid refractory IBD patients with CMV colitis. And as I've said, discontinuation is then recommended in patients with severe disease and symptomatic disseminated infection. The ECHO guideline, or the revisit or the consensus revision in 2021, goes on to discuss other viral infections in IBD. They discuss viral hepatitis, particularly hepatitis A and B, and the emphasis about vaccinating these patients as well. The treatment of chronic hepatitis B and C should mirror that of patients without inflammatory bowel disease. And then they have discussion about hepatitis E, which we see now. There is a possibility of chronic infection with hepatitis E, particularly with genotype 3. And that could pose some difficulty in patients with IBD should they have hepatitis E. Treatment with ribavirin. There is not yet a vaccine against hepatitis E, but it's not only acute infection anymore. There is this possibility of chronic infection and should be considered. Antiretroviral therapy for HIV is the sort of cornerstone in this population as well. The entity of attenuation of IBD, if we look at the GET-AIDS study, we see that the requirements in patients with HIV for immunosuppressants, biologics, both in Crohn's disease and UC, seem to have been less in that study. And it gives this idea that HIV attenuates IBD in this, I'm hesitant to say beneficial way, but there is this interesting dynamic with regards to HIV. But the HIV treatment should mirror that of the non-IBD population, and CD4 counts should be monitored in those patients with IBD and HIV. Herpes simplex, again, appropriate timeous antiviral therapy should be instituted should you have HSV on board with IBD. And again, in the immunocompromised patient with systemic HSV infection, you may not always have the classical skin involvement or herpes dermatological manifestations to have systemic severe disease with acyclovir. So that should be considered. Epstein-Barr, we've talked about a lot with regards to the thiopurines and their oncological cytotoxic predisposition, and that one should consider that the risk of lymphoma and HLH in patients who have not been exposed to Epstein-Barr, and the use of thiopurines then in these non-exposed patients should be carefully considered or revised, or one should try and look at other alternatives in those patients. Influenza, which we are seeing now, that COVID has passed on or given light or rest to allow these other flu viruses or viruses to take hold. I think we do see influenza now, and I think the risk of severe influenza is definitely a difficulty with IBD patients. So annual influenza vaccines are advised, and it's advised further to avoid live vaccines in those who are immunocompromised. Human papillomavirus, again, should not be ignored in patients with IBD. Annual cervical cancer screening is advised in females, and then vaccination for both males and females with IBD is advised in the current guideline. And then lastly, this story about SARS and COVID. I think IBD management is said now to follow the standard of care, even in the setting of SARS and COVID-19. The Secure IBD study showed nicely that there were certain factors like age, comorbidity, disease activity, and combination therapy that were associated with severe disease. But interestingly, contrary to what we thought in the beginning, anti-TNF monotherapy and other biologics were not associated with severe COVID-19. So those patients should continue on their therapy, should there be any association with COVID-19 or problem with COVID-19. And then vaccination, while I'm not aware is directly trialed in IBD, it is advised in this population as well. So this is just a snapshot of sort of the viral infections in IBD. And with regards to the ECHO practice guidelines revised in 2021, we thought to just go through some of the salient points that are relevant in this problem of opportunistic and viral infection in IBD, just to be wary of them and keep them in mind when seeing your IBD patient. Important, the initial screening and preventive measures when you make a diagnosis in someone with IBD. And then again, the story of the therapy, to appreciate the immunosuppressive therapy risk, especially with combination immunosuppression both for the increased risk of infection and the problems that I've alluded to regarding the immunization of patients with IBD and the timing that should be done early and preferably before initiating immunomodulatory or suppressive therapy. And then I refer you then to the echo practice guidelines, which we found useful in our setting to help with these patients that we've seen. And thank you for your attention.
Wow, great talks to both of you. And thanks for bringing up this topic. We don't often review it, it seems. I'm not sure why. But I think, again, excellent presentations. And thanks for reviewing the guidelines so well. We do have a question from Phoebe. Hi, Phoebe. She says, my impression has been that opportunistic infections, even discounting TB, are more common in immunosuppressed IBD patients in sub-Saharan Africa than in other parts of the world. But I don't know if there's any real evidence for this. Should be interested to hear from the panel on this. Wayne, Jill?
No.
I'm not aware that there's anything like that. But it's definitely something that we need to look at. I think as time goes on now, we definitely are seeing opportunistic infection as a problem in our patients with IBD. And I think as time goes on, we will have to start looking at it and looking at the different types of infections and not just grouping them like the ECHO have done in just one document and clumping them all together. And I'm sure we'd find interesting differences between viruses and TB and fungal infections and so forth. Yeah. Thank you.
Jill?
Yeah, so there really is no evidence to support that, Phoebe, but I sort of kind of agree with you that I've sort of had that feeling as well. But of course, we do have the dual epidemic of HIV, so there are reasons that we may have a double whammy here.
Yeah. Before I go to Nassif's question, Jill, did you have any comments or questions on the presentations?
No, I thought they were both fantastic. Thank you very much.
Really
just a couple of things. So for the herpes zoster, we do not have the inactivated vaccine here in South Africa. We've only got the active vaccine, which you cannot give to somebody who's on any form of immunomodulator or anti-TNFs. So yeah, unfortunately, that is a problem. And what you do see in clinical practice is that you ask the patients if they've had a history of chickenpox, you do their varicella zoster IgG, it comes back negative, no history of chickenpox, you want to vaccinate them, but they need to be immunosuppressed and you haven't got that time period to wait to give live vaccines. So this is just something that we've encountered in clinical practice, which would be circumvented by the Shingrix vaccine, which is available in the States and some countries in Europe.
So that would be circumvented by the immunoglobulin, because given the number of days you can give immunoglobulin.
No, I'm not talking about somebody who's been exposed to chickenpox. I'm talking about somebody who's got serology that is negative at diagnosis or hasn't given you a history of chickenpox.
Okay. And then while we are on that, don't forget nosocomial spread. So if a patient has got active oozing lesions, Wayne, like you guys did, again, if you, the caregiver, has not been vaccinated or has not had chickenpox, it's actually not ideal to be around the patient. They need to be isolated until the lesions are dry and crusted. So I was wondering, was he in the hospital in isolation room or when he had those active lesions?
Yeah, so fortunately, I saw him myself at the clinic. I do know that I've had chickenpox, so okay. I think that was
so
easy.
You're the right man to go into the room.
Yeah, so I'm the one that took the pictures. I think it's not difficult. It seems that when people, well, initially we didn't know. If you look at the picture, it's quite atypical. Initially we thought, is this maybe zoster? He actually said that he thought he had chickenpox before, but it didn't follow a dermatomal sort of distribution. I didn't show that picture now, that it was actually non-dermatomal. But when we saw and we entertained this thing of chickenpox, it's not easy for people to sort of run around and say that they've not been exposed and can they be excused type of thing. So I think the awareness seems to be there with chickenpox, but we definitely isolated him. He had to go back to Kimberley where he was isolated there. And then in 2 days' time, he was actually sent home. And he completed his oral course at home. And he really had, interestingly, an uneventful course. But yeah, we do emphasize the containment measures in the hospital. And then your point about the immunoglobulin, I think in terms of the non-availability of the vaccine now to give within the immunosuppressed patient, it's actually what you have. So like in this case, you have to watch the patient and advise them. And those that have been exposed, the tool you have is the immunoglobulin to administer within 10 days, it seems, until we get the optimal vaccine available. So yeah, that's a problem for us as well.
Yeah. Nasif, he says, in patients that are HIV positive with low CD4 counts, varicella may be present with prominent neurological features such as strokes, etc. Is this seen in IBD on anti-TNF agents, or is it mainly a skin and bowel disease, CMV? So I guess he's asking, do we see a lot of neurological manifestations of CMV in our IBD patients?
He asked about varicella zoster, I think.
Oh, sorry, varicella zoster,
but, I think CMV can be an equal question.
Oh, yeah. CMV can be an equal question, yeah. He's asking about varicella. I don't know. I mean, I haven't seen any patients with neurological manifestations of this. And I was thinking about your patient, how lucky he was that he responded so well and didn't seem to manifest any other organ involvement. But I can't say personally I've managed this, Jill, over time.
Yeah, so I haven't seen any neurological fallout from varicella zoster. Certainly it causes the dermatomal issues. The drug that is all of our drugs that we have available to increase the risk of varicella zoster, but it's particularly tofacitinib, which is available in South Africa. I don't think it's available anywhere else in sub-Saharan Africa, but it is associated with a 6-fold increase in varicella zoster. But fortunately, it seems to be single dermatomes, usually doesn't cross the midline, and it's never, very, very rarely reported to be disseminated. So it doesn't seem to be much of a significant problem, and certainly not something that I've encountered personally.
Which is just as well.
Yeah.
Any other questions? Wayne, I'm glad you raised the issue of immunization for human papillomavirus, because the guidelines say age 11 to 19 or whatever it is, but actually I think we should be considering vaccinating anybody really, even beyond those ages. I've seen papers that do suggest that, whether they're IBD or non-IBD, just to vaccinate young women, but also, as you say, in the context of IBD, even the men. Do you guys do it routinely, or how do you manage that?
Yeah, we definitely don't do it routinely at our clinic, and it's something that we're going to look at now. I think it's important to, at least in this population with IBD, we should be vaccinating both the men and the females. So I think it's a start there as well. The males was a new thing for me. So I would think, but yeah, it makes sense to vaccinate them both.
Yeah.
So that's reasonable. Yeah. So that's definitely included in the ECHO guidelines now. That wasn't previously, but yeah, I think that's important.
Yeah. The problem is that they would have to pay for it themselves, adult patients, and it's actually not that cheap at all. So I'm not sure how feasible it is for our patients in state practice. It's not really feasible at all, unfortunately, because as you said, it's limited to young women, young girls, should we say? Yeah.
Girls.
I must say the rollout in schools has been very effective, and if you look at, I mean, I've got 2 young girls in my, that I have, and we've had to entertain this question, and it seems that if the rollout can be so effective in schools, I would think that we could do it in the IBD population, but yeah, I think it's something.
But it's not for adult IBD patients. They would have to pay for it themselves because it's not part of our national guidelines of immunization. Yeah.
Yeah.
Sure.
All right. We've got exactly 2 seconds left of our time. I'm assuming that there are no more questions or comments. So it just leaves me to really thank everybody for your attendance, to thank the speakers. Excellent talks. I must say, I thoroughly enjoyed them. So thank you very much, Jill, Wayne, and Ram. I really, really appreciate the contributions and also the knowledge that we've all gained from the session. I'd like to thank ECHO at the University of New Mexico, as well as the ECHO India team, who always have our back in terms of the technological stuff. Thanks to Cheryl and Karen, on whom we count. And the recordings are available on the Gastro Foundation website, as are all the recordings since we started this GECO movement. And thank you to the sponsors, without whom obviously we cannot function. So next week is the GECO endoscopy session, and Galia and Matt are presenting. You don't want to miss that. I find that their sessions are always very instructive and very informative. So with that, I wish you a fantastic evening and see you next time.
Yeah.
Thanks.
Evening, everybody.
Thank you. Good
Bye-bye.
evening.
Thank you. Thanks, Wayne. Excellent. Wow.
Thank you.